floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
So hello, everyone, and welcome to episode 243 of the Crisis Jam. We are going to be featuring today a spectacular debate on how states should prioritize building capacity in the three core crisis services. And we're honored to have Paul Galdys with us and Dr. Joe Parks. And again, as a reminder in this, it is not really a debate, but we're going to be talking more so. They will be talking about the best strategy to get to the best level of care. And I'm really looking forward to that. And in basis of introductions, I'm Dr. Brian Sims. I'm a senior medical advisor with the National Association of State Mental Health Program Directors. And I am just thrilled to be your host for today's jam. So looking forward to this upcoming jam. Want to look at the top 3 episodes, and when you're looking at these numbers, you're looking at the number of people who have connected through the YouTube upstream measure. And if you notice, it is huge in terms of the most recent ones that we've had on the live chat on location in Franklin County. You look at the numbers, just phenomenal. And what it is showing us is that a lot of people are responding to the Crisis Jam and are coming on board in greater numbers. It's a reminder also that you can connect through crisisjam.com, where we're shaping the future of crisis response, and again, doing it together. And in that, what you will find is all sorts of resource materials, ways that you can register if you haven't done so already, to watch it on live stream, to be able to stay in the know by going to the newsletters that are available. You're also able to see many of the previous episodes, and you can actually go into the library and take a look at some of the episodes that have occurred. Now, if we go to the next one, righty, you can see where the Battle of the Bills have taken place, and in the Crisis Jam itself are lead stories. But when we do the YouTube uptakes, you will see all sorts of prior episodes that you're able to connect to. And give us a like. Take a look at it and see what you feel. Now, I want to move to our breaking news. And the breaking news, I'm going to ask Matt Goldman if he'll come in to provide us our opening for this breaking news event. Matt, if you're there.
Hi, I'm here. Hello, everyone. Great to see you all. I'm Matt Goldman. I am in King County, which is the Seattle metro area, where I serve as the Crisis System Medical Director for our crisis continuum here in the county in Seattle. And I think David Covington asked me to join here to share a bit about this news story that was just shared, produced by Converge Media, which was covering all of the major advancements that we've been undertaking here in King County, in particular, implementing a crisis care centers levy that invests $1.25 billion of taxpayer funds to expand and implement a full crisis continuum in the county. So I think there might have been some video or something that David wanted to play here, which hopefully the technology works. And so I'll pause for that.
Matthew, we actually played the video in the pre-show.
Oh, you did in the pre-show. Sorry, David, I missed that cue. Okay. So anyways, I think the things that I would just highlight from what we're doing. So yes, there's the emphasis on building out full crisis continuum here in King County, from call center to mobile to crisis facilities, and then post-crisis follow-up. And this was really just a media coverage that highlighted that there's a strong focus on meeting populations that are otherwise underserved, a strong cultural and linguistic focus on our services being appropriate for a range of populations, And we continue to invest. So we've got one of our centers open and operating. We have 4 more that are in development and will be opening across the county, including one that's dedicated fully for serving youth. And then we're also investing in our mobile crisis programs for both adults and youth here as well. So appreciate the opportunity to share an update that there is a lot of action happening here in King County still as we really invest in expanding these resources.
Matt, thank you so much for that info, and remind people that the information, you'll have links in the chat room. You can certainly refer to it. Thanks so much, Matt. I want to move to another segment, and this is something some of you may have seen on television over the past weekend, where one of the NFL games had highlighted a moment of silence for both the passing of Paul Tagliabue, but also they spoke about the apparent suicide of Marshawn Nealon. And just wanted to raise awareness, because if you did see that episode, what you also saw was an outcry from the NFL about making sure that 988 is made available, that you do call upon it. So these kinds of events, again, are raising awareness, and hopefully can be words that are spread in all venues about sometimes these tragic events that do occur, and that how powerful and how positive 988 can be. So remember, we went through the debate before? Well, wanted to take a look at a pre-survey on this debate, and that's how we kind of do things. We kind of set the stage here, and you'll learn the data later on. But as we take a look at this one, we should focus on the 3 core crisis services, not a broader crisis continuum. How are your feelings on that? Are you definitely no, not sure, yes, or definitely yes? If you'll submit your response, we're going to kind of leave the poll up there as we move on. But just want to give you an opportunity to have enough time to be able to respond to the question, because this is really helpful information for all of us. Righty. And want to talk about the policy foundations for a new era of crisis care, because in this, there have been a number of papers and developments that have taken place over the years. And some of the most recent ones has been SAMHSA's roadmap for the ideal crisis systems. But all of these are built from an earlier one done in 2005 on the community-based comprehensive system of crisis response that SAMHSA had developed. And it kind of was the core for the other developmental services that have taken place. All righty. Now, with that information, we now want to move to our crisis hot seat. And we have today on our hot seat, we have Becky Stoll with Centerstone and Anita Iyer with Mount Sinai. So if you are both available, there you are, Becky. I can see you there. And is Anita joining us? And there she is. Wonderful. Thank you both for agreeing to participate in this. And again, as it is for the hot seat trivia questions, we are talking Crisis Jam swag. So for both of you, regardless of the responses to the questions, you will get a gift code that you will be able to select your Crisis Jam swag of your choice. So if you all are ready, let's start with the first question on the Crisis Jam. At the 2019 Crisis Now 2, the global convening that took place in Washington, D.C., the leaders agreed on a guiding principle that would later anchor SAMHSA's 2020 national guidelines for behavioral health crisis. And the question is, what was it? The choices that we have available: anyone, anywhere, anytime. A, B, right time, right care. C, keep calm and call 988. Or D, call, connect, be kind. So Becky, Anita, any thoughts on this?
Anita, I know it's A or B.
Yeah, I was thinking A or B as well. Go with your instinct.
Righty. Well, what we've done is put the poll out there, so let's see what the audience has to say on it as well. And if that shapes it and maybe further determines whether it's A or B, let's see. The audience seems to overwhelmingly, almost 3/4, feel that it's A. So does that help shape anything as far as your responses?
I was gonna go with B, but Anita, do we go with the majority?
Yeah, when I first saw it, I thought B as well, but I think, yeah, let's go with the majority.
All right,
Righty. Well,
Brian, we're gonna go with A.
then that's your final answer, and it is indeed the correct answer. The 2020 national guidelines emphasize that there was no wrong door safety net services that provide diversion from law enforcement and hospitals anytime, anywhere, anyone. So
Yeah.
thank you for that. Now let's move into this declaration that you see from the Washington Declaration about crisis care, and you can see it woven into the language, not only the Washington Declaration, where you see anyone, anywhere, anytime, but in the SAMHSA National Guidelines for Behavioral Health Crisis Care, where you've got a toolkit. In it is woven those same versions, and anyone, anywhere, anytime.
A time has come for this. Nom, nom, nom.
And that is our introduction of our over and under question. So if you all are ready, just ask in the beginning. What we do is we ask a question, and then one of you can either choose to give a guess, and the other can do whether or not they feel it is over, under, more positive, more negative, whatever the question would mold. So do either one of you, would either one of you like to be in either position?
I'll defer to Anita. Do you want to make the guess or do you want to over under?
I'll over under it.
Okay. All righty. Very good. Well, as we look at the polls here, we're looking at a guideline that had been given already. So what you're looking at something that was actually posted, I believe, last week. I talked about crisis residential units and counseling units and all of those basic molding patterns that give us all of the data that we need. And it's all referring again to the 2005 report to respond from TAC and from SAMHSA on the community-based comprehensive psychiatric services. So in our over-under question, the 2021 roadmap to an ideal crisis system policy paper actually listed 11 elements of the continuum. So on the over-under question, in 2005, TAC published the Crisis Response Services monograph. How many service components did they list? So in that 2005 publication. So Becky, you have a number?
I'm gonna go 5.
5. Okay. And Anita?
Yeah, I was thinking 5 as well. Do I have
Okay,
to over under, or can I just agree with Becky?
You can do any of them as you wish.
I'll go with Becky.
So you're going to go with Becky on 5. Very good. Well, actually, the answer is 8. And you can see them listed here, but again, they walk through all of the basics of everything that we've talked about. 24-hour crisis telephone lines, the warm lines, the walk-in crisis, all the way to transportation were the key elements in this particular report. So guys, you did wonderful. You did absolutely spectacular. Thank you so much for participating. And again, reminder about the Crisis Jam swag. Use your gift codes and maybe adorn those the next time we see you here on the Jam. So thanks for coming. We're going to move next to our lead story. And in the lead story, we are bringing in a debate. And this debate is actually debate number 9. And it's 9 debates since actually season 3, when this all began. And it's going to be on best strategy for building services, focus on core versus comprehensive. And we have with us Sherry Senwelski, and she is going to be our moderator for this, and she is the Vice President of Crisis Care at D.D. Hirsch. So Sherry, I'm going to hand it over to you.
Thank you, Dr. Sims. And thank you for giving us that great history of planning of crisis care systems over the last 20 years. with the rollout of 988, we've really seen sort of the planning for our systems of care be supercharged. 988 being the front door for those systems. And then what do we need to have on the back end? Paul Galdys was involved as the lead author of the SAMHSA National Guidelines for Behavioral Health Crisis Care, where there were 3 strategies recommended for that planning. Dr. Parks from the National Council was primarily involved in the publication of the Roadmap to an Ideal Crisis System, which got a lot more detailed. So there was more rooms to that house, so to speak, behind that front door. We're going to debate a little bit today. You know, Dr. Sims said it wasn't a big debate, but I saw these guys prepping earlier, and I think they're ready for a fight. So I can't wait to see what they have to tell us today. Paul's going to start with the affirmative, telling us why he's recommending those 3 strategies as we're doing our preparations.
Thank you, Sherry. I firmly believe that states seeking to advance crisis care should prioritize building capacity within the 3 core services of 988 and local crisis lines, mobile crisis response, crisis receiving and stabilization services, representing resources within a system that each offer real-time access to care for anyone, anywhere, anytime. This 988 Crisis Jam community is here because we've all answered the call to action. We've held steadfast in our commitment to end the unacceptable and tragic outcomes that have faced individuals in behavioral health crisis for decades. Mental illness has been criminalized, with freedoms lost to de facto criminal justice system responses. And some have lost their lives during law enforcement responses to a call for help. We see others in crisis wait in hospital emergency departments for hours, days, and even weeks to access care. Still others simply go without ever being offered support, resulting in harm and even loss of life that could have been avoided through timely connection to focused crisis care. We must apply precision and focus to ensure accessibility through the 3 core components of a crisis system, core components that connect individuals to needed services and catalyze advancement of a continuum of crisis care based on the unique needs of each community. As W. Edwards Deming stated, systems are perfectly designed to get the results they do. And you can see the results of our current system within the headlines on this slide. If we want to realize different outcomes, then we must change the system. Changing systems in a manner that impacts behavior is exceptionally challenging. Change is hard. There's comfort in the familiar, and our communities are very familiar with how emergency services are accessed. Call 911. EMS will come to wherever you are, and EMS will bring you to the emergency department, or you can go there yourself. And all of these serve as a path to connect to a focused emergent response without fear of being turned away or rejected based on a prerequisite criteria. However, this hasn't always been the case. During the Vietnam War, our military operated mobile army surgical hospitals, or MASH units. Those of us that watched the 70s TV show MASH saw Hawkeye Pierce and Hot Lips Houlihan in action, saving lives every day through timely, accessible responses to emergent needs, when and where they were needed. In 1966, the National Academy of Science issued their accidental death and disability report that indicated individuals in acute physical health distress fared better on the battlefields of Vietnam than they did.
Paul, I'm going to have to stop you right there. You're doing a great job in this debate, but I got to make sure that Dr. Parks has his 2.5 minutes.
Well, I think we're 5 each.
Are we? I thought it was 5 total and then 5 for the negative. Okay.
5 each. 5 each.
Then keep on going, Paul. Keep on going.
So as we leaned into that accidental and death disabilities report, indicated individuals in acute physical distress fared better on the battlefields of Vietnam than they did on the streets of our cities that have healthcare throughout. This spurred a movement to change, to focus on core access points. 911's first call came 2 years later in February of '68. Community-based EMS services evolved, and eventually hospital emergency departments that previously turned people away accepted everyone as EMTALA expectations were solidified in 1986. The 3 core pillars of someone to contact, someone to respond, a safe place for help became a reality in the physical health world. Clarity and simplicity. The 3 components of this emergency care system drove implementation and sustained the approach for decades. Why wouldn't we replicate it? Unfortunately, the system built to respond to emergent physical health issues has failed to meet the needs of individuals in acute behavioral health distress. The essential first step to changing these outcomes is to ensure access to care that feels caring to the person and their family. The presence of a coordinated system of crisis care with 3 core components is the foundation that must be in place, offering a clear and very familiar 3-component approach that equitably serves all in need. Someone to contact, someone to respond, a safe place for help for all without fear of being turned away. Look, when we build a house, a bridge, a sandcastle, or practically anything with layers, we prioritize creation of a solid foundation that can be built upon, expanded as needed. I firmly believe that the essential aspiration of crisis care is to offer equitable access to care that feels caring to the person and their families when and where they need it. Realizing that aspiration requires precision and focus. Without no wrong door access, we will continue to incarcerate, board, and feel the crushing weight of tragic outcomes that are too avoidable. We cannot connect a person to residential treatment, in-home supports, or respite if the person in crisis never is engaged in care at all. Build the spine first and then attach the limbs. Prioritize your foundation. It will serve you well on your path to the ideal, coordinated, purpose-built crisis care system. Thank you for the opportunity to share my thoughts.
Thank you, Paul. We're going to turn it over to Dr. Parks, who's going to show a more comprehensive strategy, 11 elements for planning for crisis care. Dr. Parks?
Thank you, Sherry, and thank you, Paul, for your great presentation of 3 of the 11 necessary things needed. They are essential. The 3 core pillars are essential, but they are not sufficient, is my premise, that we need more if we're going to respond to crisis overall. Let's show the 11 items here. Go ahead to that. There is just more to it in order to respond completely to crisis and to get far enough upstream. A crisis system really should be a healthcare delivery system that is crisis capable throughout. It shouldn't be a separate system in and of itself. And when we focus on the 3 core pillars to the exclusion of other items, we present it really to ourselves and to others as a separate system, not as a capability of the whole system. And in that way, we really let everybody else off the hook, and we miss a lot of other opportunities. It is just too simple to meet the diverse kinds of crises that occur in the diverse communities that crises occur, in all the different conditions and situations that they occur. Show my next slide. It would be great if it was that simple, if we could do just 3 things. That would be much easier to execute. It's hard for healthcare systems and communities to execute on multiple things, but it doesn't get the job done. Why doesn't it get the job done? If a crisis is met, they call, somebody comes out and gets them, they have a place to go, it's all fine, and we discharge them. To what? You have to have the other services out the back to decompress the crisis services, but also to prevent readmission to crisis. Let's face it, there's people that go into crisis again and again because they can't get to the ongoing services in a coordinated, ongoing way. And what about all the opportunities upstream? If you think about it, having long waiting lists, a waiting list for treatment is actually a waiting list for crisis to occur. All those people need something and they're not getting it. One way to reduce crises so you don't need as much mobile crisis or receiving is to take care of people promptly when they first ask for care. Another way to respond is when people show up in a crisis for the place that they show up to respond to the crisis instead of calling for an outside service. This is a CCBHC requirement. CCBHCs have to have the ability to do a crisis response if somebody shows up to some other service in crisis. This is good and necessary. It reduces demand and it's upstream and then the crisis is responded to by the usual treatment team or people more likely to have more intimate direct knowledge and be able to do more appropriate treatment rapidly just because they've been around the person, they know them. Mental health first aid. This makes crisis response everybody's responsibility. Crisis detection and response. People are all over the community. Even the best teams take a while to get there. Isn't it better when crisis training and crisis response is an embedded capacity across the entire healthcare delivery system? This is more complicated. It's harder to pull off, but it keeps it from being that other team's job. No, I don't have to see people that quick. We have a crisis team. No, if they're getting upset, let's call the crisis team. I can just keep on doing my little thing and not have to have that level of flexibility and responsiveness to be there when people's conditions change. It does demand more. You have to be able to individualize your responses as the individual's condition changes instead of only be able to respond to their needs at a certain level of service. So my assertion is that Paul is right. The core services are very important. They are necessary, but they are not sufficient. We must have other services so we don't have crisis recurring. We must have upstream crisis capability, crisis awareness, and ability to respond short of and prior to even the person realizing they need the care. I work for an organization and we've instituted what we call health check questions. Wherever we're doing even just a social help, like getting a food box or helping with housing, we always say, well, how are you doing physically? Is your asthma a problem? Well, how are you doing emotionally? Are you getting overwhelmed and irritated? Well, how are you doing with those medications? Are they not working? Are you having trouble? Are you not getting them? We call it a health check.
I'm going to check right in now, Dr. Parks. Thank you so much.
No, don't show that one yet. That's my close. You blew it.
I'm going to hand it back over to Paul. Paul, you've got 5 minutes now to argue now that you've heard the other side from Dr. Parks.
Whoa. I actually think I have two is the rule. I'm going to follow the rule.
I don't know how I have messed up this timing. I even took notes on this, so I apologize, but I'm glad you're being honest. Thank you, Paul.
But let me say this. I'm going to start with fantastic job, Joe. Sherry, appreciate your support. Brian Hepburn tried to get us worked up before this debate, but I have a tremendous appreciation for all you do. It's always a pleasure to join the Jam and truly appreciate any time I can spend with Joe Parks. A crisis system should not be used to replace a continuum of care, but to deliver access and connect to those services. Funding and workforce limitations make us prioritize. Change is hard. The three core component framework of an emergency response system is not only familiar, but analogous to the physical health system, positioning mobile crisis and facility-based crisis receiving and stabilization services to secure parity reimbursement from managed care organizations, pulling in a multitude of payers, dramatically reducing dependence on state, county, and local funding. Long-term sustainability should be the expectation, an expectation that can be realized within these core services. And we cannot forget that the roadmap to decriminalize mental illness, end psychiatric boarding, and connect individuals and families to care that feels caring will require precision and focus. Let's prioritize offering viable access points to anyone, anywhere, anytime. We know what this looks like. Someone to contact, someone to respond, a safe place for help. Once the foundation is in place, communities should continue to build based on their unique needs and available resources. Thank you for allowing me to be a part of this important discussion today and really appreciate all the points you've been making, Dr. Parks.
Thank you, Paul. What do you have to say to that, Dr. Parks?
Oh my God, Paul is formidable. Usually it's easier for me to get my way, but Paul is a formidable communicator. So I really appreciate the strength with which he puts his points. But I still maintain that the problem with focusing just on these three services is twofold. Number one, it should be done not at a state level. We shouldn't presume to decide for communities. Communities differ, systems differ, and we should prioritize. But who should prioritize? The local community responsible for the care should prioritize. They should look at their opportunities, their gaps, and it could be that what they need most is a place to call, somebody to respond, and some place to go. But some communities may decide that they have other opportunities that are riper, other needs that are more pressing, and they should make that locally in consultation with each other to come to the correct decision. Because in the end, crisis systems are not state systems. They are local community systems. They always vary at that more granular level. And then I think the second point is again, we want it to be one system, not systems that work together. I certainly agree with sustainability. The path to sustainability is to have the money flow in a way that the efficiency of one can go to the efficiency of others. Crisis services save huge amounts of money. When they run as a separate system, then it's hard for them to get money from the other system because the other system sees it just as a loss. I think by showing ourselves as a separate system and not being an embedded capacity, we actually cut ourselves off from the big bucks that would get us sustainability. You know what we really need is we need these three core services to be essential health benefits like ERs and ambulances are. So it's not considered credible insurance unless it's covered. That's a real parity issue. And that would make it part of the overall system. So, Paul, I like your passion. I know you're well-intentioned, and now I'll show my last slides. But I think if we're separate is never equal. And if we want to be equal, if we want to be effective, we got to be in it with the rest of them, which means it has to have crisis capability everywhere. Thank you.
Thank you, Dr. Parks. As the moderator, I'm lucky to get to ask you guys a couple of questions, and these are some strong arguments that you're having. And I guess I'm wondering a couple of things. I'm going to start with a question for Paul. Paul, we've seen such a sea change of people really paying attention to crisis services like they never have. 988 really got us the attention that we've been looking for years. And I'm curious if you're advocating for just focusing on these three core important elements. How do we make sure while we've got stakeholders' attention that we don't lose sight of all the other things that we're wanting them to support and fund?
Yeah, it's a great question, Sherry. Look, we certainly don't want to lose ground on anything, but keep in mind the efforts that have built these crisis systems have largely been driven by one-time funding from American Rescue Plan, COVID relief, and one-time SAMHSA enhanced dollars. Getting to sustainability is something Joe and I both believe in, and there are certainly mechanisms to work our way there. I think he's right that we have to get to these being identified as essential health benefits, which means coverage, make them all sustainable. All things can go. What I'm suggesting is not that we carve out and consider a crisis system separate from a continuum of care. But what I am saying is we have to focus energy on making sure access happens first. We're not delivering help to people that are in jails and prisons. We're not delivering help when we can't find them because they're left on the streets. We can't help them, unfortunately, when they get caught in an emergency department for days and weeks at a time. These are the sort of things that I think have to be tackled, and we have to have a comprehensive approach. But until we get connected to those individuals, I don't know how we can do the rest. And the other thing I'll say is Joe's absolutely right. I would never suggest that we lean away from the strength of outpatient services. We don't want people to go into crisis. And just like we don't want people to go into physical health emergencies, we also know our communities have to have emergency departments in their hospitals because they happen. And so we have to be prepared for them. But of course, we should be strengthening these systems. And Sherry, we should not lose ground on what we're developing. We just have to focus on this core foundation first, from my perspective.
Thank you, Paul. Dr. Parks, I'm wondering, as you're advocating for these 11 elements as part of strategies and communities for crisis care, I'm thinking about my own home state of California, and we've got a 5-year plan that we're working on. And I'm operating a crisis center in California, and people have seen this plan, which is great news. And they're knocking on our doors and they're wanting all of it right now. And so how do we prioritize when we've got 11 elements like this? How do we even know where to start, and how do we manage expectations?
Yeah, I think one way to prioritize is to look at your rate limiting step. Where are your choke points and where do they pile up? Are there crises that were avoidable earlier upstream? Are there people stuck in crisis observing because you can't move them on because of housing? Are you seeing readmissions where people come back to a mobile crisis visit because they were waiting 2 weeks for an outpatient visit? I think you need to look at your choke points. And the way to get support is to be very transparent with your data, to say, here's where we're failing and why. And here's what the resource we need to fix that failure point. Community, what's the more important, meaningful failure point to you? Give them some choice, get them involved in the debate of what's more important. Don't make that decision yourself. Let it grow some heat, because heat causes motion.
Wonderful. Thank you, Dr. Parks. We've got just a couple of minutes for some closing statements. Paul started us off. That means you get to start us off now, Dr. Parks. Give us your closing statement.
I just want to thank you for your great facilitation. I want to thank Paul for the powerful way he made his points, and I like my 11 services better than my last zinger slide.
All right.
Thank you.
Thank you. And how about you, Paul? Any last words for us?
Wow, I can make it quick. Look, I would love to have 30 services that align with the needs and get to the ideal is right. We shouldn't stop until we get there. What I'm saying is we have to tackle the thing that's right in front of us and has been there forever. We have to make a change so that access is available to everyone, equitably available to everyone. And once we get there, of course, we want to evolve and solidify. And the only other thing I would add here is when that term of sustainability, look, we have core concepts that work that are analogous for parity enforcement on some of these services. We should push hard on those now. And there's no reason to stop. We should be adding things like respite, residential, and others into those parity arguments as we go. But we have to start getting wins with the insurers, start getting them to contribute so we're not relying on local taxpayers to fund healthcare. There is a solution for all of us that make these things all affordable.
Y'all, I just want to thank you so much, Paul and Dr. Parks, for this wonderful debate today. As the moderator, I'm going to stay neutral. I think for me, seeing the passion that both of you have for planning these crisis services across the country and in local communities is inspirational. And whatever way people go, as long as they're focusing on crisis systems within their communities, we're going to be better off. So thank you both for inspiring us today.
And Sherry, I want to start off by just thanking you for corralling these two individuals and keeping them focused. Wonderful debate. I'll get on the semantic side of talking about whether or not it was heated or otherwise, but just a lot of wonderful information coming from both of them. So thank you so much. And thank you also to Paul and to Dr. Parks for spirited discussion here. I'm going to move to the Roundtable Live, and we say it's Roundtable Live, but we're going to do a little bit of a change because Dr. Hogan is not able to be with us live today, but we do have his video recording of comments based on this. So go ahead.
Let me start with my perspective on developing crisis services. And it comes from lots of places. It comes from developing them in my relative youth. Serving on the Lifeline Advisory Committee, working to develop the Crisis Now model, 25 years trying to run state mental health systems, and then having family members receive crisis services of both the police variety and the mental health variety, and seeing how that went. And so my perspective is not a particular point of view. It's not a provider point of view. It's not a trade association point of view. It's trying to look at the whole field. And my assessment from that is it takes all parts of the Crisis Now model working together to achieve our goals. Yes, somebody to call. Yes, somebody to respond. Yes, a safe place to go. And then an additional element that is complicated to put in place. And that was what David has called air traffic control or coordination of that system. You've got to have all of those parts working together. And the necessity of all those parts, in my point of view, becomes particularly important when we're trying to provide crisis services, not just to people that the behavioral health system is used to taking care of, but when we're really trying to avoid a lights and sirens response and have people go to the emergency department and jail. So if we, in my point of view, develop crisis services that are basically set up to support the mental health system, that is purely insufficient. We've got to address these problems of criminalization and people being involuntarily committed when community alternatives would be possible. So if we're not focused on those whole community-wide goals, parts are great. People's lives can get saved in a call. Crisis residential is certainly nicer than inpatient. But to me, it seems like a focus on 11 or 13 or 25, sort of elements of crisis system is kind of goal displacement. It becomes focusing on putting parts in place, not having a system that can meet people's needs. Nationally, we kind of have much more of a focus on getting calls answered than we do on the rest of the crisis continuum, which is true for lots of historical reasons. And calls are great, but sometimes people need care now. Focus on the core elements of call, response, and a place to go seems to me to be more important now than ever. And I don't believe that we should let the quest for, the quest for the most desirable be the enemy of the good, particularly when the good is providing care to people instead of having them end up in jail or an emergency department. So let's be about the whole thing and do it right. That's my perspective.
Dr. Hogan, thank you so much for that. And again, the emphasis on all parts to achieve the goal. Let's now hear from Becky Stoll. We're going to bring you back, Becky, as Senior Vice President of Crisis Services, Center Stone. What's your perspective on the debate?
Don't hear you, Becky.
Sorry.
Okay, there you go.
Am I back? Okay.
Yes, you're there.
Yeah. I really thought when I was listening to Mike and Joe and Paul, it reminded me of 1996 when I bought my first home. I'd always lived in a small, tiny apartment as an adult and bought a house that was so much bigger than this little tiny efficiency apartment that I was in for $300 a month. And when I moved in, I wanted to obviously furnish the whole house, the living room, the kitchen, 3 bedrooms. Oh my, 3 bedrooms and a dining room. And I didn't have the money for that. We, were my ex-husband and I didn't have the funds to immediately do that. And I remember telling my mother and my grandmother, I thought we were not going to buy a dining room table. And my very Southern grandmother clutched her pearls over that. Like, you've got to have a dining room table. I think what has been said for me is this is the North Star. We have to have these comprehensive systems everywhere across the country so that everybody has access. But I at that time was not like my neighbor who maybe made more money than me and could furnish their own home like on the drop of a dime. I had to be thoughtful and purposeful about what rooms were important to me. So I think we have to let communities all understand what the North Star is, what that tip is, and where we're all headed. But I think it's up to communities to decide how they get there, how they fund it, and what do they need now if they can't furnish the whole house and they're going to have a plan. Maybe they don't have to have the dining room table. Maybe in their community, they're more focused on having a kitchen table and a bed. And I don't think it's up to all of us to tell them that. I think it's up to the communities to figure out with the funding they have available, what their needs are and what's going to serve their community as we incrementally all aim for that North Star. And
Wow.
side note, I'm sitting in the same house in the dining room and never had a kitchen table. And it's an office. So, it's all different. And I think we need to make sure states have that leeway.
Rebecca, what a wonderful perspective. And I want to thank you for your coming in and giving the comments here. And I want to also thank Dr. Hogan for the comments. This was a wonderful debate, and I just appreciate the comments that have been made. You've given folks a lot to think about. So we are now in the post-debate survey. Now, we put out the survey a little earlier about whether we should focus on the 3 core crisis services, or should we look at a more comprehensive, broader crisis continuum? So I'm going to ask again for your responses. What are you thinking now that the debate has already taken place? And we'll post these results later on through the Crisis Jam and for next week. So you see it posted here. Please give us your responses. You can continue to give also comments in the chat if you so wish. Had some wonderful comments that have already been placed there, but we'll keep this up so that everyone will have an opportunity to join in on this post-survey debate. Righty. And we're moving next to the briefing room where we would have had SAMHSA, but with the government shutdown continuing, we are hopeful that they will be returning soon. So we're going to move to the NASHBID update. And our NASHBID update for today, we have Dr. Deborah Pinels, who is our Senior Forensic and Medical Director with NASHBID. And Dr. Pinels, wonderful to see you, and please go right ahead.
All right. Well, thank you. And what a great debate to think about. So I'm delighted to be here. Hello, everybody. I am going to be talking a little bit about what we're working on at NASHBID. As many of you know, we work on technical assistance papers and presentations on topics that are of national interest to all the partners that we have at the table in the crisis space. And one of the papers that we're working on with SAMHSA and our experts is the issue of psychedelics in psychiatric treatment. And this is a hot issue. Thanks, Paul. You do too. This is a hot issue and something I think that in the crisis space we need to be aware of because it's going to be coming up more and more. Either the people that we're seeing will say that they have experienced this because some people are doing this off the record, so to speak, but also there's a lot of research going on about getting approval for these medications to be administered in a therapeutic setting. We already have ketamine that we use for treatment-resistant depression, and ketamine is used through infusion. It is the drug itself, the medication itself, that's used to help people, and it helps through what we call the NMDA receptors. Now, the psychedelics have somewhat different properties, and they actually work on serotonin receptors. The 2 main ones that are being researched are psilocybin, which is sometimes colloquially known as the magic mushroom, or MDMA, which is also colloquially known as the ecstasy drug. And when it's been used as a substance illegally, then those can be substances of misuse and cause all sorts of problems. However, what is thought to be the case preliminarily is that they do have also some therapeutic value. There was early research that was stopped years ago, and now it's coming back into the fore. And what we think is that these medications may help improve kind of damaged neural circuitry. We think that they may help repair and in certain ways where we have harm from either trauma, depression, or even substance use disorders. And so we don't really know fully yet how they work or whether they will in fact fully work. But the idea is that these would be medications that people would take, and they would be associated also with some assistance through therapy. So instead of medication-assisted therapy, it would be therapy-assisted medication, if you will, although that's not a formal term. I just kind of made that up. But the idea is people would prep, they'd take the medication, and then there would be some processing of what the experience was. afterwards. Now, I myself, have been watching this literature and wondering where it will go. I'm very focused on providing evidence-based care. So we are still learning about this, but because it's such a hot topic, it is something that we're going to be writing a paper about that will provide some technical assistance. These, of course, have their own challenges too, just like any medication. There's side effects. There could be cardiac side effects. There could be the risk of psychosis. So we have to think about them in our populations of people who already have substance use challenges or psychotic disorders or bipolar disorder. We don't yet fully know what all the risk benefits are. And that's hopefully what some of the research will help us figure out. But I wanted to, and we at NASHBID wanted to alert you that this is something that we're going to be working on this year. And so you'll be hearing more about that. Clearly in your crisis work, that's going to be something that may come up, that people may have experienced and may share and may be experiencing going forward, especially if these things do get approved fully for therapeutic use. So with that, that's our NASHBID update. We look forward to providing more technical assistance on any number of topics related to crisis services. And I'll turn it back over to Brian.
And as always, Dr. Pinos, thank you so much for that very, very comprehensive overview. Gives us a lot to think about going forward and looking forward to whatever papers may come out of NASHBID in that regards. So thank you so much. I wanted to put this slide up. It's from last week, if some of you remember, just kind of giving us a highlight about what's going on in our environment and what we see and don't see. So it's a great segue to move into our next segment with the Advocates for Human Potential and the Workforce Center there. And we're going to bring up Susan Lang, who's with them, and Dr. Michael Sofis. And Susan, go right ahead.
Thank you so much, Dr. Sims. Thank you for having us today. So this is our monthly Workforce Corner. When we were together last time, we talked a lot about using data to really drive and understand what's going on in the workforce. Today, we're going to dig in a little more deeply. Over the next couple of months, actually, we're going to talk about the data-driven approach. Today, I'm joined by my colleague, Dr. Michael Sofis, who's a behavioral scientist. And Dr. Sofis is going to speak to the work that we've been doing across the country to get real-time data to understand what's going on in the workforce. So it's really the quantitative approach. And then next month, we're going to dig in on the qualitative approach. So with that, I'll turn it over to you, Dr. Sofis.
Right. So what we do in general for our data related approach is we try to collect data at scale with anywhere between 1% and 5% of all behavioral health workforce in any state that we might work in or system or what have you. And the goal is really to be able to have current data and whenever humanly possible, repeat those assessments across time and repeat them across different levels of behavioral health workforce stakeholders and ideally even patients. And so there's a couple of projects we're doing now where we are literally going all the way from, supervisors to, behavioral health workforce direct staff implementers down to patients, while also assessing the impacts of scalable, software as a service solutions and other types of behavioral health workforce solutions. And so the goal here, right, is to be able to, one, scalably involve a large number of folks, to be able to involve, at least, like I said, 2 to 5% of the workforce, and to be able to actually essentially predict, because of the comprehensive nature of being able to assess so many different variables and factors and outcomes in the same individuals, as opposed to many federal data sets where we're 8 questions here or 8 outcomes there. It's completely disjointed at different time periods. From a methodological standpoint, from a scientific standpoint, can't do a lot with that data at scale often. Whereas here we can, verify it, we can validate it. We use, scientifically validated items in the surveys. And so we can actually, in some ways, use predictive modeling, machine learning to make solid inferences when controlling for real world outcomes. And a lot of this work is direct implementation level assessment as well. All right. Next slide, please. And so loosely, for those of you who aren't as research focused or scientifically minded, the goal here when we do this work is we really layer it with as many comparators as possible at the same time. So it's rare that we just do one state alone. We're often doing neighboring states, or if we do a county, we'll have neighboring counties or all counties in a state, right? We're trying to go apples to apples and make comparisons. And whenever, again, when we can, we do that across multiple time points to create trajectories. So think of it as a more nuanced, targeted, enhanced version of sort of population surveillance, but for behavioral health workforce. And so there's factors or contributors, right, that go into these models that can affect many things that both directly impact people's lives, their quality of life, the business outcomes for the larger system. Everyone loses in a lot of these scenarios. And so there's a lot of work that we're showing that there's a lot of sort of bystander effect, for example, where folks are thinking about their own organization or their own system when it comes to things like turnover. But what's happening is there's a rapidly increasing number of people at scale in the country leaving the field in general, higher than other industries. And so it's a bigger problem and everyone's going to suffer for it, but no one really wants to kind of take the lead, if you will. All right, next slide. And so just as like kind of an example here, we have a map of the United States. Obviously, this is from, we have about 6,000 behavioral health workforce that have completed our annual survey. Over 100 factors, outcomes, services, quality outcomes, there's process outcomes, there's, patient wait lists, things like that. And to really understand how these systems and individual employees, groups, organizations are working within, across, around each other at scale. And so what we find is a lot of individual differences in all the way down from a state, all the way down to a small group within an organization in terms of what is driving actual people to leave their job. And oftentimes, this is just an example of where we have other variables in this model that we're controlling for. And so above and beyond that, what we're seeing is that the patient waitlist for every month, on average, there's about a 7 or 8% increase in the odds that they're going to quit their job. So when you think about the average waitlist in some of these places, 6-7 months, all of a sudden, you're seeing a much higher rate. And so that's just one little example of what could be pinpointed, but it could be very actionable and very repeatable. And our hope is to really, in any way, sort of work with folks, collaborate in a way that we can get some of this information out there so that folks understand this is knowable information. All right.
Last slide. Thank you so much, Dr. Sofis. So, again, this is a quote from one of our partners in Oregon. We did some work on predictive analytics to understand who was entering the behavioral health workforce there. I've said this before, the way we're going to get to meeting the needs of folks who are in crisis is making sure that there's a robust workforce. So really understanding what's going on and getting real-time data is the way that we get started with that. So with that, we will close. Next time, we will talk about our qualitative analysis work to hear from the voices of folks who are doing the work of the work. And with that, I'll turn it back over to you, Dr. Sims.
Thank you so much, Susan. Thank you, Michael, for wonderful presentation. I'm going to hand it over to Kristen Ellis, who is going to take it from here. Kristen?
Thanks, Dr. Sims. Big thanks to Paul and Dr. Joe Parks for that lively debate. Two sides with one shared goal. We want to build stronger crisis systems for everyone. Again, thank you to AHP, one of our headliner sponsors. If your organization wants to help sponsor the jam, now's the time to reach out. We're always looking for more support to keep this jam going. And please don't forget, Crisis Now 4 is going to be in July 2026 in Washington, D.C., our international convening. It's going to back up right after the annual NASBID meeting in the same facility right near the National Mall. It's a beautiful place, and it's going to be a really good convening together. Next week, we have Sophie Chev and Michelle Zabel talking on advocacy and the future of crisis care. You know how we like our fireside chats. And then the following week, if you can believe it, we're in the Burr months. Utah, it is pretty cold, but we're in the Burr months, the holidays. Then we're going to take a short Thanksgiving break. We're not going to have a jam, just gratitude and maybe some good cranberry sauce on your table. And then the following week, for I believe it's the first week of December, if you can believe that. We're going to be back with Tia Marcel Moretti. She's going to be telling us a little bit about rapid response, the real impact, the Ohio MRSS story. I don't know about you, today's debate was really fun. I kept going, oh my gosh, good one, Paul. Oh my gosh, Joe, you just got him back. I'm actually not sure which side I landed on. I thought I had an idea before we started, and now I think I've gotten pretty neutral. Do we just want to have a really big crisis response system that everybody can access? Kind of like the poll talked about, anytime, anyone, anywhere. We want to be able to have all the services the person might need in their care. But again, thanks for watching, everybody. Please tune in, log on, and join the movement, and we will see you next week.